All right. So I'm Pam Kryskow. I'm a physician from British Columbia, Vancouver Island, and I am the medical lead of a nonprofit called Roots to Thrive. So for my disclosures, I am the medical chair of the Psychedelic Assisted Therapy program at Vancouver Island University. I'm a clinical instructor at University of British Columbia. I'm the medical lead on the nonprofit Roots to Thrive, and I'm a board member of the Psychedelic Association of Canada. I have no conflicts, or financial conflicts related to this on ketamine, other than I'm the medical lead of this nonprofit program. In Canada, we like to do a land acknowledgement to honor the First Nations on whose land we work and play. And I have the privilege of working and playing on the Klahoose and the Snuneymuxw First Nations territorial land, unceded territory. So Roots to Thrive is a nonprofit that started in 2019 in British Columbia. And we do two different types of group psychedelic therapy. We do psilocybin assisted group therapy for people with end of life distress and treatment resistant depression. And we also do group ketamine assisted therapy for people that qualify with inclusions of either PTSD, depression, anxiety, disordered eating, substance use issues, OCD, and other mental health challenges such as grief and burnout. The program itself is a 12-week program. It's built really more around resiliency, and what we kind of have a slogan in the program is "Come for the psychedelic, but stay for the community," because we think that's really where the healing comes. Is mostly people are craving connection and community and love, and when you give that to people, a lot of the challenges of their life start to be mitigated. So we piloted our program with 17 nurses who were burnt out with and had PTSD and were off work. And every single one of those nurses after the 12-week program went back to work. And in fact, a majority of those nurses have now joined our team as nurse therapists. And they have been there to continually to iterate and make the program better and better every time. Now we treat first responders, firefighters, paramedics, police officers. We focus on frontline healthcare people as well, veterans and their families, and normal, like people that are not in those categories as well. You can qualify for the program. We published last year in Frontiers of Psychiatry on our research. And publishing this type of research is really important because these are real patients in a real therapy program. And it's not a clinical trial, they're not randomized. If they get into the program, then they can and they consent, then they can be published in the research. And what this does is it allows other therapy programs or other people that need to bring these type of therapies to their populations to use this type of data. These are complex patients that mostly would not make it into clinical trials because they have multiple comorbidities. The other thing is it's a real program that's constantly iterating. So the program is not static. It's in a constant quality improvement process. So if there's an improvement we can make on the program, it is implemented immediately. And so the data is not super clean, but it's still important, and it really allows us as a therapy team to focus on patients and getting the best service to patients. So 83% of those who started the program with PTSD at the 12-week mark no longer had PTSD. 91% had clinically significant reductions in generalized anxiety. These are all measured through validated clinical measures. 79% clinically significant reduction in depression, and 92% rated their life-work balance improved. We had 92% attendance rate, which is really unparalleled in this type of work to have patients show up that regularly. So the program looks like this. The first 4 weeks, and in fact, what I should do here before I go into this is just talk about my biases about this. So when we started this program, I was incredibly biased. I was biased against ketamine. I'm more of a psilocybin person. I was biased against group work. I thought individual, one-on-one or dyad work was gold standard. And I was also biased against online, like Zoom. I didn't think you could get that connection online. I've been proven wrong on every one of those, and I love that. I love being wrong. That's where I get to learn. So our program looks like this. They get 4 weeks of preparation at the beginning online. So they meet, they come together. There's very skillful questions that help bring them through their preparation process and getting to know themselves, getting to get embodied, getting to understand how they approach life, their thought patterns. And they're doing this online in their small groups. So they have 8 patients in each small group with 2 facilitators. So they spend about 2 hours and 15 minutes a week online, working through the questions, getting to know each other. Week 4, they come together in person. They meet each other for the first time in person, and it's like watching a family reunion. They're hugging. You're taller than I thought. You're shorter than I thought. You're wider than I thought. And they're truly joyful. They're giving each other's hugs. It's quite interesting. Their ketamine journey is together in the same room. So 8 patients from the group that they've got to know, along with their facilitators, and then the team is there, and I'll tell you a little bit more about the team in a bit. They have their ketamine session, and then as they emerge from their ketamine session, they have their first integration. They start to talk about it in group. They have 3 more drop-in sessions that they can attend if they want. They can attend all of them, one or none, and where they continue integration with facilitators. And then it goes back to online for 2 more weeks of integration and taking themselves to the next level, starting to integrate what they learned in their ketamine session and talking about it and learning together as a group. They come back on site for another ketamine session, their second one. Same process, very ceremonial, by the way. And I'll get into that again in a few moments. But very, very ceremonial. And then they repeat the process, integration for 2 more weeks, back on site in 2 weeks, and then 4 weeks at the end of preparing for what they've learned, how they're going to integrate it in their life, and ongoing and then I'll tell you a bit more about what happens after that. But in the meantime, all through that 12 weeks, they have the option for drop-in sessions for many of our patients have many other challenges other than the mental health issues they're dealing with. Many of them have chronic pain issues. Some of them want to learn better lifestyle. So we have functional medicine specialists. We have a sleep specialist. Many people have sleep issues alongside of that. And we also have psychiatry drop-in because we see very many of the same themes emerging. And we have really noticed that when they can drop into the psychiatry sessions and bring up their concerns, there's 2 or 3 other people that have the exact same concern. And they really start to see that they're not alone, that they're not in this silo of I'm the only one with this unique or terrible challenge. So like I said, we meet on Zoom. The vast majority of the program is on Zoom, other than the psychedelic therapy. And then that's kind of a representation of what one of the rooms look like. We're actually in a new place now that's a little bit nicer. But they come together. They have these wonderful mats that are super comfortable. They can have more mats if they want. They have weighted blankets, which was like life-changing for our program when we early on moved to the weighted blankets, and people felt like I felt so held and safe under that blanket. We have 2 music makers on our team that make custom playlists for each journey. So that's based on what are the challenges. So I don't know how they put that together so well, but they put together the most beautiful playlists. Each patient has their own headphones that's tuned into that. So it's kind of like the silent disco headphones. So they can adjust the music up or down. So they can have pretty much silence, or they can have full-on music, and they can take their headphones off and the music's playing in the room. They all have eye shades. And our team has a lot of Indigenous knowledge keepers and Indigenous team members on. And one of the main teachings from Elder Duncan Grady, who's a Blackfeet elder, is that when you work in ceremony on yourself, it's so important for you to go in and down. That's where the healing is. That's where your inner healing intelligence is. And so for that reason, that's why they all have the eye shades. So it's congruent with First Nations teaching on whose land we operate this program. So as I said, it's a group process. There's 2 facilitators that travel consistently with the 8 participants in each group. And we actually run through, for a bigger picture of the program, it's actually a whole cohort of people that are going through. So in the cohort that just started last Tuesday, there's 6 groups of 8 going through. So they're going through in their little pods, but they're all going through the same pace. So our therapists and the overall team we're kind of promiscuous in the modalities we use, and we follow the kind of the belief system that the best therapy is the one that our therapists are really good at. So they can mix and match a little bit here, and the whole team is constantly meeting to see where the patients are at and what are the lessons that are most relevant. And so then we may tap into different things, but all through the program, the patients are being taught about unconditional positive regard, that they're worthy just as they are. It doesn't matter what challenges they have. They're born worthy, they're worthy, and that in itself is really a beginning for rebuilding that foundation of mental wellness. And compassionate witnessing, which is just being heard in those small groups when somebody is sharing what their challenges are, and those other 7 participants are witnessing and hearing that and leaning in and going, wow, when you say that, my heart aches that you feel so alone. You can imagine that therapeutic, that just elevates the healing in a way that I've never seen, and has really won me over to the group process. Because in the one-on-one, I now look at it a bit more transactional, and I don't want to offend anyone who does one-on-one or dyad. I think it's still really powerful. But, I'm there as the therapist, and, at the end of the time, I go my way, they go their way. But in this process, they're there with 7 other people that are slowly becoming their colleagues and their friends, and they're still continuing to talk and move forward. In fact, we give them buddies in the program, and that was one of the feedbacks we got, like, wow, it's the first time I've ever come into a program and got assigned a friend. And they are friends, they actually become friends. So our team is very diverse. We have Indigenous elders, Indigenous knowledge keepers, we have medical doctors with multiple specialties, we have nurses, nurse therapists, we have energy workers, we have functional medicine, clinical therapists, and somatic therapists. The energy workers are the favorite therapists on the team. The patients consistently say that in that ceremony, when Helen or Darlis came over and they just held my feet, I just felt so grounded and I felt so safe, and I was able to go deeper than I thought I could. So they're always the favorite. And we have spiritual care people on our team as well. So the diverse team, our team being so diverse, has tons of benefits. And it's a non-hierarchical model. It's a flat hierarchy. So me as the MD, I'm not at the top. So we're all learning from each other. And there's such a privilege to be able to learn from so many professionals that have so many skills, that it feels like our whole team is constantly getting more and more learning, trauma-informed care, cultural sensitivity. And it's just a really lovely way to be working in teams where you're always going to be in that lifelong learning and you're always learning from your colleagues. Safety is incredibly high, and I think what can derail these therapies being available is safety and transgressions, and that is like the highest importance on our team, that our patients feel secure, held, and safe. And when you're working in a big team like that, the team is always watching for red flags. We're always watching to make sure that there's no inappropriate interactions. And if we see something that doesn't feel quite right, we have a culture of leaning in and bringing it up and talking about it. So there's no shadows. We turn the light on as bright as we can to make sure that there are no transgressions, because what we're doing for these patients really matters to us. It really matters that we do no harm. And we will do harm. But if we know that we've done it, then we need to lean into it and fix it and make the system even better. And so when you have a big team, you can do that. You don't have, that one-on-one where you just may not know if you have caused a transgression. And then the therapeutic alliances for the participants, if they're really feeling that they need something different, then they can have different therapeutic alliances with different people on the team, especially because we have so many of these drop-in extra sessions that they can move into. So I mentioned this already. The drop-in groups are psychiatry, chronic pain, sleep challenges, and functional medicine. They change a little bit here and there. Sometimes we get a few more things. And already talked about that. Let's keep going. And the group benefits, definitely, I mentioned at the bottom there, the buddy system. So the first day of the program, they get assigned a buddy. And so this also adds more to what they get through the whole program, because at least once a week, if not more, they check in with their buddy, which might just be a text message, it might be a phone conversation, it might be going for a walk if they're in the same geographical location. And they're talking about what the challenges that are coming up, but also leaning into the questions of the week and their own experience. So we see that also. We see them coming back, into the group and saying, so and so and I had this conversation, and it really helped highlight this learning I had last week or in my ketamine journey. So you can see that there's another layer there of integration for them. The accelerated healing by far, and this is where one more groups really won me over, is to see the epic jumps that the patients were taking, much faster than I'd ever seen in dyad work or one-on-one work. And I just find it remarkable, and it really decreased their silos of the healing, because so many, especially in the first responders, so often when first responders start to have mental health challenges, and I mean, I was a city firefighter for 8 years before I went into medicine, and so I'd seen it all the time. But you get more and more insular. You hide more, you stop going out, you stop going to the social activities, and then before you know it, you're, like a friend of mine said, you're sitting at home in your underwear, drinking beer all day long. And that's what the worst place to be. That's where suicidality comes from. So they drop the silos, because in the small groups, they're learning from each other that, hey, that person has the same level of shame I do. That person has the same upbringing I did, and I really like them. And if you never worked in groups, it's just, like I said, it's just such a magical thing to see this elevation of wellness. So they gain friends and colleagues. So at the end of our program, we don't just you're not just done and out and gone. We have a whole alumni program that allows them to continue to have all the resources. They can go to the drop-in groups. They can continue to meet. In fact, we have groups that still are meeting on their own without the facilitators. They get together once a week. They watch one of the teachings. They take some of the questions, and they have their own little mini session together, and they're continuing their own healing. They've owned it. They're owning their own healing. They don't need us anymore. And as a physician, that's my greatest happiness, when a patient no longer needs me. That's perfect. They continue to meet. And then if in the alumni group, if they want, they can also apply to have, thank you, they can also apply to have another a ketamine session in a small group. And it's interesting, because I'm so glad you bring up the addiction portion. I think that is so important. The most we've had, and we follow our patients out to over a year, but the most we've ever had anyone have of ketamine sessions is 10. That's the most. Some of them have, in fact, even in the program, even though it's 3, some of them have not had 3. They're like, I don't need the 3rd one. And that's the difference, because they're in a community. They're in a community, healing together, connecting with humans, which is really what we want. We don't really want ketamine, right? We really want connection and love and community. So 10 is the most, and that person, in fact, I have permission to share this, is that her last 4 ones was not at all for any of the mental health challenges. She was like, I just now need to lean in to learn what are my blocks to being a better parent, to being a better. So now she is using her sessions to move into more wellness and to just showing up more fully in her life as opposed to dealing with mental health challenges. So the cost of it, this is the whole reason we brought it into the nonprofit, because this is not yet covered in Canada fully. And so we needed to bring the price down as low as possible because we don't feel these therapies should be a have and have not situation. That's not fair. We have scholarships. We turn no one away. If they qualify for our program and they can't cover any of the cost, even on a payment like $5 a month for 20 years, whatever. We have a scholarship program, and that we fundraise actively for that with foundations to make sure that no one is ever turned away from the program. But as you can imagine, we have such a big team, so many offerings. This is what the price comes down to. And we were about to just publish on our data with a health economist who was able to crunch our data. In BC, we have BC population data stats that we could case control to. And if a person came into our program and only had depression, only had clinical depression, we saved the healthcare system $30,000 that year. So it's quite a cost savings. We were unable to get the cost benefit of the more complex, they're much more complex than just depression. They have PTSD, substance use challenges, and we follow substance use challenges all through the program, and we see a drop off right by week 4, even before they've had their first ketamine session. We see a drop off in alcohol use, in nicotine use, in cannabis use right off the bat. So we've had lots of people come through our program with heroin addiction problems, and they go through the program, they do quite well, and we keep a really strong container around those folks until that heroin issue is no longer an issue. We have scholarships, I mentioned that. I love this one. I love the psychedelic artist. This is Autumn Sky, a BC artist. But I like this because these hands just really show how much better we are together as a team, and this really just embodies what our team believes in. So we talked about the nonprofit, the diversity of the team. I'm just going to add just a few other little things. Is for the dosing, I didn't put it on the slides. The dosing, when we decide what the person is going to do for their dose, it can be anything from nothing to up to 1.5 milligrams per kilogram. We do IM dosing. And we have had people the first or second time not do any ketamine at all. They just have joined their group, and they have just listened to the music and laid on the mat and just experienced that. And the very first 2 we had do that had remarkable changes just by being in that room and being able to be part of the group. So we allow that. And then the dosing is individual. We don't have a formula that we follow. It depends on their intention. It depends on their experience with non-ordinary states. That includes meditation, sweat lodges, and any other psychedelic experiences they've had at all. So we try to figure out what their comfort is and then what their intentions are. And they help co-create the dose they are going to have, so that they can own their healing. And we don't want to be dictating this is going to be your dose. And so our doses are all over the place. People have a wonderful psychedelic experience in the medicine at very low doses, as low as 0.5. And some people, we have to work around sometimes other medications that people are on, like benzodiazepines. And so some of those people have been pushed a little bit higher than 1.5. And we watch them very closely and take good care of them, and they do quite well. So as I said at the very beginning, we're continuing with these community trials. On Tuesday, we started our firefighter trial. So we have firefighters, a whole group of firefighters going through that will be watched. If the firefighters, which we have many firefighters come through our program, and every one of them have resolved their PTSD, that's a cost savings of $220,000 to the system for a firefighter being off work. So we're hoping to keep that going. And there's no one size fits all. That's why our program is so diverse. And we really do want to do what is best for the patient. We don't know what's always best, and we're in a constant iterative process. So we have an anonymous feedback form that that we supply to all the participants from day one. And we say, be as harsh as you want. We can handle it because we're here for you. We're not here for us. We're here for you. And so if there's something we can do to make this better, that's what we're going to do. And I think the difference here, too, or not the difference, but just another alternative to like Zoe's presentation, which was really eye-opening and interesting, is culture matters, right? We're not all the same everywhere where we are. And the culture in British Columbia is a little bit different. It's very thoughtful, and what we do is very ceremonial. We have Indigenous elders on our team. From the moment people arrive on site, it's quiet, it's thoughtful, they feel held, they feel taken care of, and they know it's about ceremony, and they know it's about their healing. It's not about getting high. It's about being able to go inward and find those things that are blocking them, finding those things that they've been holding too long, and really, really working with that. They stay in ceremony during their medicine. They integrate in ceremony. They leave the building in ceremony and walked carefully and quietly back to their ride at the end. They stay on site for a long time. They can be there for up to 5 hours. There's no quick Uber rides home. They can stay, they can percolate, they can draw, they can talk, they can listen to music. And that's why I said earlier, like, we really do believe that, they'll come at first for the therapy, but they really do stay for the community and the connection and the love. And I really honestly think that's why our success rates are so high. And I think it really matters. So if you're working with these medicines, how you work with them and the way you work with them and your teams matter. That's our team, constantly growing. Thank you.